Ladies and gentlemen, it gives me great pleasure to welcome you all to Parliament Buildings today, and also to welcome those who are joining with us online for this special event with Northern Ireland Chest, Heart and Stroke. For those of you who don't know me, my name is Pam Cameron. I'm presently the Deputy Chair of the Assembly Health Committee. For me, this is a first opportunity to sponsor an event physically within our beautiful building since the pandemic began. Many thanks to Health Committee colleagues, Colin Gildernew, Chair of the Committee, and also Paula Bradshaw for co-sponsoring this event today. As we begin, I would ask attendees today to be mindful of the safety guidance in place for social distancing and encourage you to avail of the hand sanitation stations around the building. Today, Northern Ireland Chest, Heart and Stroke will officially launch their Stroke Manifesto for 2021. An important document that lays bare the situation that we are facing in Northern Ireland in terms of services and care. Many of the problems facing our services have existed for some time, but have now been exacerbated further by the COVID-19 pandemic. The need for reform and transformation in our health system could not be any clearer than it is today. I'm sure, like me, you'll be looking forward to hearing from our event speakers today on the very important topic of stroke reform. This manifesto gives a very clear list of recommendations which would go a long way in addressing the waiting lists and underinvestment, and helps to put the issue of stroke service reform back on the public agenda. I'd like to give a special welcome to all of our guest speakers who will be addressing us today. And at this stage, can I now welcome Declan OCallaghan, Chief Executive of NICHS Chest, Heart and Stroke, to come and make the first contribution today. Thank you.
Hello, good afternoon everyone. I'm Declan OCallaghan, Chief Executive of Northern Ireland Chest, Heart and Stroke, and I am delighted to be hosting this event as we attempt to ensure that stroke, including its prevention, acute care and aftercare, is once again on the policy agenda of government as we return to some kind of normality after 18 months of upheaval. You're all very welcome, whether you're present here in Parliament Buildings in Belfast or joining us online from Edinburgh, Dublin or elsewhere. I'd like to thank Pam Cameron, MLA, for sponsoring this event. It's vitally important when raising issues as significant as this that we are seen and heard by our legislators and decision makers. The past year and a half has been a very challenging time for all of us in Northern Ireland Chest, Heart and Stroke. But seeing the isolation and the anxiety of the people that we support during that time has made us even more determined to win the battle against chest, heart and stroke illnesses. Stroke, even aside from the lives that it claims each year, is the single biggest cause of disability in Northern Ireland. The cost implications for health and social care are clearly huge. For that reason, today's event focuses on stroke reform. I am delighted that we will have an opportunity to hear from Professor Rohan Collins from Dublin, who has been leading on the development of a stroke strategy in the Republic, and from Professor Gillian Mead from Edinburgh, the incoming President of the British Association of Stroke Physicians, BASP, which, like Northern Ireland Chest, Heart and Stroke, has a strong focus on the care and rehabilitation of stroke survivors. Catherine Murnan, our own Director of Care Services, will describe how we have adjusted to the challenges of recent times. And then finally, we will hear from our Chief Medical Officer, Michael McBride, who has played a crucial role in steering the health service and political decision makers through massive challenges in the past 18 months. As I look at stroke care and prevention, I have a certain sense of déjà vu. When we in Northern Ireland Chest, Heart and Stroke were asked to run a pre-consultation exercise back in September 2018, reform of stroke care was already well overdue, as was increased investment. 3 years later, many things have happened, but sadly, reform of stroke services is not one of them. Political uncertainty, including the collapse of the Executive and the Assembly, has undoubtedly been one of the factors in the delay. I pay tribute to our health professionals working in this field. They've continued to drive improvements in stroke care across Northern Ireland, and this is evidenced from the SNAP audit. It's testament to their achievements. The COVID pandemic has, of course, had a hugely negative impact. We know, for example, that the resulting disruption has caused the thrombolysis rate to fall considerably. It will take us some time to assess the full impact on stroke, but we already have no doubt that it has been significant. Even without COVID, however, I'm not sure that stroke reform would have progressed at the necessary speed. The pandemic has been around in Northern Ireland since early 2020. Stroke has been the victim of neglect for much longer than that. That's why I want today to mark the start of a change in mindsets, a change that will deliver the stroke services that the people of Northern Ireland deserve. The Health Minister, the CMO, and the entire health and social care system are continuing to battle COVID, but they're also beginning to consider the broader issues of the health service. The trusts have drafted detailed rebuilding plans, though sadly the references to stroke services have largely been notable by their absence. The Minister and the Department have brought forward plans such as the cancer strategy and more recently the substance abuse strategy. We note too the Minister's plans on elective care and his very welcome attention to our terrible waiting lists. We hope that all the political parties will come together to tackle the waiting list issue. Frankly, however, not enough has been said about stroke. Hence the reason we're running today's event and why we have drawn up our stroke manifesto, a manifesto that calls on all those involved to take action in key areas: prevention, acute hospital reform, proper long-term support in collaboration with the voluntary sector, and ultimately a Northern Ireland stroke strategy that will deliver tangible results. In recent years, we've seen much attention focusing on improving treatments such as thrombolysis and thrombectomy. The problem with that is obvious. It only happens after the event. Not enough attention, and this was one of our criticisms of the consultation process, has been given to prevention. The rest of the UK, and indeed Europe, has been alive to not just the challenges of prevention, but also to the opportunities. Unfortunately, we are still lagging behind. We're delighted to see prevention included in the work plan of the Integrated Care Partnerships, the ICPs, but we need to see more. We need detailed and ambitious plans, for example, to increase detection of AF, atrial fibrillation, and hypertension all across Northern Ireland. Both measures would save lives and reduce the incidence of people living their lives with a disability. We must be more ambitious because the current lack of ambition in this area is failing the people of Northern Ireland. It was because of our concerns about this that we commissioned an inquiry into AF conducted by Dr. Niamh Kennedy from Ulster University. I'm delighted to see Niamh's joined us here today. Her investigation, conducted over the course of a year, involved discussions with clinicians across Northern Ireland. The findings and the recommendations remain relevant, and it's good to see some of them being reflected in work that's currently been progressed. This includes the development of a clear clinical pathway. COVID mustn't be allowed to push AF or other preventative measures down the health agenda. I would argue, in fact, that we have an even greater imperative to avoid preventable illness at a time when the health service is under such pressure. All of which brings me to our manifesto. We want to see firm commitments backed up by clear timescales on 4 particular points which we raised in the consultation. The first is 24/7 assessment for TIA, or mini stroke as it's known. The second is hitting a target of at least 20% for thrombolysis. Thirdly, we want to see an achievable date for 24/7 thrombectomy. And finally, and crucially, we need a date for a decision, or even better, a decision on which hospitals will become hyperacute stroke units. We also need a timeline for early supported discharge from hospitals to be available across Northern Ireland. And let's be honest, in some areas it remains quite a way off. The other area of the consultation that lacked detail, in our opinion, was after stroke support. The Stroke Association's report, Struggling to Recover, attempted to assess the scale of the problem, but we've seen no detail from the department board or trusts about how they plan to address it. We don't expect miracles, but some kind of plan would at least be a start. Finally, it's too often forgotten that there's a wealth of skill available in the voluntary sector. We're ready and willing to play a greater role, but we must be seen as a valued partner, and we must be properly reimbursed for the work we do on behalf of the trusts. Before I finish, I'd like to remind you that copies of our Stroke Manifesto are available here in the long gallery, and it's also available online on our website. I know my assessment of the current situation may appear quite harsh, as there are some good reasons why things have not moved as quickly as we would have wished. But we need to start a new way of thinking, how things can be done, rather than reasons why they can't. We in the voluntary sector are ready and willing to play our part, as we have been all along. As the voice of people who are too often voiceless, we'll continue to encourage good practice, but criticise whenever we think it's merited. I've spoken just about Northern Ireland, but let's now widen our scope to the rest of the UK and Ireland to see if we can draw any encouragement from what our colleagues are doing. Our next speaker is Professor Rohan Collins, who, in addition to being a stroke consultant in Dublin, has campaigned for improved stroke services in Ireland and has been leading the development of a stroke strategy. So I'll pass over to Rohan now.
Thank you very much, Declan, for the kind introduction, and indeed congratulations to you and indeed to Pam Cameron for sponsoring this. Let me say at the outset, it is with deep disappointment that I was unable to be with you in Parliament Buildings in Stormont today, as I was very much looking forward to seeing Stormont, but unfortunately the rota did not allow that at last minute, so I do apologise. Hopefully we will get a chance to meet one another in person again, because I think it's important. Great ideas are shared, I think, when we meet in person. And so thank you, Anya, for the opportunity to speak to you all today. So I'll try to share my screen now, which hopefully will work reasonably well. It seems to be going okay anyway. And not a time to be asked for how to improve your presentation. But in any case, I wanted to give you an update from the Irish National Stroke Programme, and indeed maybe give you some thoughts, and also maybe just speak a little bit about the effect of the pandemic. First of all, congratulations to Northern Ireland Chest, Heart and Stroke. I believe it is your 75th anniversary. So many congratulations on that, and for the huge amount of work you do, as does your sister organisation down south, the Irish Heart Foundation. Who am I? Well, I'm a Cork graduate originally. I still have some of my Cork accent. And then I completed my master's in Trinity in Dublin. I worked in the NICHS, where I finished my stroke training, spending 6 years in lovely Yorkshire, and before returning to Italian University Hospital in Dublin. So that's just a bit of who I am. And when I'm not doing stroke, I like to go fishing, but I can't remember holidays. But hopefully we'll get back to holidays at some stage in any case. So just at the beginning of the pandemic, a few thoughts. This is my own hospital looking at our emergency admissions. And you can see the pandemic starting in March 2020, there was a dramatic dip in our kind of monthly admissions, the emergency department admissions. And of course, we were quite concerned that stroke patients may not have been presenting. Certainly there was a trend of them not presenting in time. And we were worried that during the pandemic that many stroke patients might be sitting at home. And in fact, that did turn out to be the case. However, if we look at the overall admissions during the COVID wave 1 for March and April, and compared with March, April, the previous 2 years, overall, while there's a little bit of fluctuation at the outbreak, the overall mean figures for both hemorrhagic and ischemic stroke were not increased or decreased, as there was some concern that there might be an increase in stroke with COVID-19 infection. Didn't seem to be the case down here anyway. Certainly then looking at, we saw a few interesting trends in terms of, for example, length of stay. both in stroke unit stay and in hospital stay. You can see once the wave of COVID-19 starts, a substantial decrease in the length of stay. Interestingly, people couldn't wait to get out of hospital fast enough, I'd say, so worried. So I think there probably was some early discharges around that dip, certainly a significant drop off in the length of stay. It's interesting as I listened to Declan's comments about thrombolysis, because we saw the exact opposite happen down south with a significant increase in our thrombolysis rate. And it's hard to factor out what that was, but I think it was probably mainly due to this, that actually the medical teams were very much front-loaded in the emergency department to deal with the wave of COVID infections. And so the time to medical assessment by the medical team was certainly a lot faster. You can see there it occurring within less than 10 minutes in 47% of cases in the COVID wave, none compared to 37%. And I think there's an important lesson to learn here, and that maybe it is important to ensure that our hospitals have ready access to an acute medical team to deal with stroke, because that certainly seems to be the driver of our increased thrombolysis. Certainly, again, looking at discharge during COVID-19, the overall discharge destinations didn't change hugely, with the one exception. And that one exception, an important exception, was home with early supported discharge. Despite the fears we had with the pandemic and that people would not want therapists visiting them at home, or maybe we couldn't do it at home by telehealth, we actually saw a substantial increase in the number of people going home compared to the pre-COVID year and the COVID wave one with early supported discharge. And again, I think there are lessons for us to learn from this. I think we can discharge people home effectively and safely with good investment with early supported discharge, which benefits patient and benefits the system. So what did we do during COVID-19? I suppose a lot of my colleagues were saying, well, what were you doing during COVID-19 in the stroke program? Well, I'm a full-time working physician as well, and I do general medical take as well as stroke. But with my stroke hat on in terms of the National Stroke Programme, we certainly advocated strongly within our own health service to make sure that stroke teams weren't completely dismantled and brought to the front line, thus disenfranchising stroke patients of the necessary MDT and expertise. We also advocated very strongly to make sure that we had safe admission procedures for stroke patients and TIA admissions during the pandemic, and got the health service to maintain our stroke pathway and to do it safely by means of screening. We worked very closely with colleagues in Northern Ireland. I worked very closely with Fiona and Michael McCormick and Fiona Quigg during the whole process, and with the British Associations of Stroke Physicians in a kind of a Five Nations approach to agree common policies. We also worked with colleagues in the UK and Scotland again on early supported discharge to agree a common policy on that for the Five Nations. And again, led a very strong advocacy campaign about swallow assessments and placements of NGs during stroke, that we consider these very much to be high-risk procedures for our colleagues who work in clinical dietetics, nutrition and speech and language therapy, and that they should have had the necessary PPE. So there was a lot of benefit to working together in this. I think it strengthened the arm of everybody working as a Five Nations, and this has led to new partnerships. And happy to announce that the British Association of Stroke Physicians will now more formally become the British and Irish Association of Stroke Physicians, and I think that will include everybody in the Five Nations of our islands as we see it currently, and so that's, I think, an inclusive way forward for us. I think there's a lot of commonality with our health services and with the problems we face with regard to stroke in the UK and the Republic, and probably much more so in common than would be the European situation. We also, of course, played a very active role with our colleagues in the Irish Heart Foundation, securing funding for the Irish Heart Foundation to run a stroke support line during the COVID pandemic, as many of the support structures would not be existing as normally. We continued our consultation process for the stroke strategy during the pandemic. And there's an old phrase in Irish, which is Ní Neartca Cur le Chéile, which means that strength comes from unity by working together. And this was a huge team effort during the pandemic. So with regard to the National Stroke Strategy in Ireland, or rather in the Republic of Ireland, They're roughly the timelines. My own view was that at the start, when I came in to take the clinical lead, is that unless you're on the program for government, you're going nowhere in terms of getting funding. And so one of the reasons we wanted National Stroke Strategy is that we wanted it to be adopted as in the program for government, and that increases the political pressure in terms of ensuring things are done. And so that was our strategy all along. And so our National Stroke Program strategy, it was a 5-year strategy. It's not by all means, it's got some criticism. And I'll freely admit it from the Irish Heart Foundation that maybe it doesn't go far enough. But my own view is that we needed a 5-year strategy that was deliverable within the time frame of a government to make it politically, if you like, valuable to a government. And we had a hashtag that we wanted to make big stroke history in much the same way as cardiology has effectively made STEMIs much rarer than they used to be. We sought to look at 5 domains around stroke prevention, acute care and cure, rehabilitation and restoration to life, education and research. And we set up a working groups with experts in each domain. And they were asked to identify up to 5 key recommendations that were realistic to achieve within 5 years, that would ensure our acute stroke units were able to provide safe, effective stroke care, that had a high impact for patient care, and that were consistent with other measures that will lead us towards the Stroke Action Plan, full implementation of the Stroke Action Plan for Europe, which I think is a very useful document for us all to aim for. And this was our first phase to lead us on that road. Of course, then there was a lot of time spent on strategic planning. Someone eventually said, would you ever get on and do something? So we eventually did get our key principles agreed. And so it was time to try and get this accepted by government. But just to give a brief view, that's what it looked like. The key principles of prevention, there was a lot of talk about lifestyle, blood pressure, atrial fibrillation, restoration to living, very important about early supported discharge, addressing the staff gap in acute rehabilitation was very important. We felt there was a need for key workers for stroke patients and maybe a stroke passport for patients, etc. And we recognize not enough psychology support. Research and education, while there was a lot of focus on academic research and education, which does drive and improve standards, we were also concerned with patient education and research as well, of course, in improving kind of public awareness. Now, with regard to prevention, we generally felt that there was 2 main age groups, the 40 to 50-year-old group where you really have a chance to intervene to change the curve. And then there's the over 65 age group where you're, to some extent, you may be dealing with risk factors that are already well established, and it's about mitigating that. The younger age group, probably more lifestyle measures and hypertension. The older age group, also important that those issues are addressed, but more of an emphasis than in AFib screening. I will make one comment, and I agree with Benjamin Franklin very much that an ounce of prevention is worth a pound of cure. I'm not a public health doctor, I'm not an epidemiologist, I'm an acute physician, but I recognize that prevention is very important. And particularly as a geriatrician, I recognize that hypertension is the root of all evil. Heart failure, coronary artery disease, atrial fibrillation, stroke, dementia, kidney failure, brain failure, blindness are all related to hypertension. And if you gave me one thing as Minister for Health, if I was Minister for Health to invest in, it would be blood pressure detection and control in midlife, because it will allow people to age healthier. It is the common illness when you've got a pulse pressure slamming the end organ day after day. And we really do need to get people to come on side with our view that hypertension is the key target, particularly in midlife. With regard to prevention and primary care, we were aware within the stroke program that there was already a chronic disease management program away. So our main aim here was to develop a clinical pathway with colleagues in the Irish College of General Practitioners and the chronic disease program to have a clear pathway for case finding, diagnosis and treatment of high blood pressure in the over 45-year-olds to be delivered at a primary care level. And again, we needed to recognise as well to work with multidisciplinary groups. We have a SPAFI group in Ireland to develop a clinical care pathway for the prevention and case detection of atrial fibrillation, which also must have a treatment algorithm allied to it. Of course, it's important you talk about prevention as well, that there's an important secondary prevention arm to stroke in patients who have had a TIA or minor stroke. And within our strategy, we want to make sure that our acute hospitals have proper TIA and secondary prevention services, and also have proper vascular surgery services to deal with patients who have symptomatic carotid stenosis. Again, it's very important that all patients who've had a stroke or a TIA have a proper access to clinical nurse specialists in stroke, to an ongoing MDT team, and also a patient education, because adherence to medication and stroke prevention, it's a lifelong work. Once you've had a stroke, it's not just for the first month or first couple of months after stroke. With regard to acute care and cure, our focus was very much on our acute stroke unit care and on our 24/7 services for thrombolysis and thrombectomy. Again, we have KPIs around stroke unit care in the Republic, that 90% of stroke patients get admitted to acute stroke unit care, and that would spend 90% of their hospital stay in it. We realize that our stroke units universally do not meet the staffing levels as recommended by Europe and indeed by the UK. With regard to thrombolysis and thrombectomy, we have a KPI of 12% target for thrombolysis, 15% for thrombectomy, which is not a KPI, but rather an ambition. We achieved 9% thrombectomy last year, which we're very proud of. We're going for a two-center strategy in the Republic. And before the pandemic hit, we were discussing with colleagues in Northern Ireland about how we can look at a 3 or a 4-center strategy for the whole island, and how we can work together to achieve that, to make sure stroke patients aren't disenfranchised from what is a very effective treatment. Just very briefly to show you, we did an in-depth analysis of all our hospitals, their catchment areas, how many stroke unit beds they have currently, what their average length of stay is, what the percentage increase in the over 65s would be within their catchment area, because about 70% of stroke occurs in the over 65s. So you could reliably project, presuming that the incidence stays the same, as to what the overall incidence or what the overall numbers of stroke would be in each hospital number area, and therefore the number of stroke beds they would need in order for us to maintain our KPIs. So we were able to actually, if you like, do a reasonably good guess estimate, presuming that stroke incidence stays the same, and that's subject to argument either way, of how many beds hospitals would need. Similarly, when we looked at the staffing, we looked largely at the UK and our own work we did in staffing levels. We looked at the current staffing levels, what would be needed for the anticipated increased number of beds, and factored all that in. We realized that that is a big HR ask and will have to be delivered over a number of years rather than in 1 year. And so there's my own hospital, for example, in terms of our current gap and stroke services, in terms of the MDTs, and then costed over year 1, year 2, and year 3. And so, for example, you can see that the total 3-year cost of my own hospital to bring us up to our full capacity in terms of our staffing is outlined there, of the region of 133,000 recurrent, obviously. So overall, nationally, that's what it looks like in terms of kind of 2-3 years, 2.3 million in the first year, 2.7 million in the second year, 2.7 million in the third year, to bring all our acute stroke units across the Republic. A total spend of just over, just in the region of shy of about 10 million on staffing costs to bring our acute stroke services, our units up to proper staffing. So again, we're very keen. We also recognize we need an extra 148 acute stroke beds designated as such across 18 of our acute hospital sites. We also realize that we need a proper nurse-patient ratios and healthcare assistant ratios, and this is crucially important. We didn't necessarily take this work on ourselves, as there's already a framework for safe nurse staffing and skill mix underway by the Irish Nursing and Midwifery organisation, and so that work is well underway, and it applies to all the hospital wards, but they are taking a specific focus on stroke as well. With regard to consultant staff, we're very keen to move away from single-handed services, which still exists in some hospitals. We feel that all hospitals need at least 2 whole-time equivalents of consultant sessions on site to deal with the whole spectrum of stroke care, and that'll probably be a cost of 2.7 million annually recurrent across the service. And there, as I said, recognises the deficit in therapists, 10.8 million was the average over cost for 157 health and social care professionals across our acute stroke units. With regard to 24/7 working, which is a key issue, how do we make it easier for people to work 24/7 and deliver acute care? One of the issues we're looking at, of course, is at software that will help decision making. A number of models on the market like rapid diffusion perfusion, brainomics, which help predict early infarction. We wanted to extend our TrustNet telemedicine program across the service. We also need to make sure that consultants will come on the rota, and that means some form of reward in terms of consultant owners working like in 1 in 3 and 1 in 4 rotas. With regard to thrombectomy, I mentioned that we achieved 9% last year. That's been done on a wing and a prayer, I have to say, to some extent. We realize that we're going for a 2-center strategy in the Republic at the moment. These will be our 2 HASUs. They will need to be staffed up at a cost of 1.2 million annually per HASU. And similarly, we were aiming to do 15% of all our ischemic strokes. That's an ambition, which would be about 750 cases, which would be a dedicated annual procedure budget of about 0.75 million. So there's staffing of what our EVT centres look like in terms of staffing them per centre. That's how we agreed with National Thrombectomy Service. You can see that 5 consultants in stroke medicine per EVT. That's not only to run their own internal rota because they're big centres, but also to receive the patients from around the country. The centre in Cork roughly taking about 35% of our population, the centre in Beaumont roughly taking 65% of the population. Moving on quickly to restoration to living, which is very important that people get back to the full life as possible. We a couple of key principles: that everyone's entitled to full information about their stroke. Everyone's entitled to have rehabilitation in their own home where practical. ESD is a proven model of care. It is the best practice model of care. We're keen that people had psychological support, which really tends to become a major issue in my own experience 6 months plus after the person's had a stroke. And everyone should achieve as full a recovery as possible. We don't think it's enough that people just get back walking. We want people going back golfing. We want people to go back fishing, taking back up their hobbies, having as full a recovery and as full a life as possible. So we felt that a couple of steps that might be needed: electronic patient passport would be useful for patients in the system. We wanted an ESD business plan to be implemented across our health service. We felt a key worker for stroke and psychological support needed to be addressed. We also realized that specialist stroke support needed to be available to our nursing homes, where patients are discharged with some of our more severe strokes and some of our more vulnerable patients. And we also realized, of course, that in terms of vocational training, that current services, particularly in the Republic, are rather patchy. So Slowing to Care is a government ambition to, if you like, move our health service to an approach to when needed and where wanted. We felt very much that early supported discharge fulfills very much that aim of Slowing to Care. And so we specifically concentrating on 21 teams across high activity sites to cover 92% for stroke inpatient population. We recognize that this, if, for example, phase 1 is implementation, full implementation across 10 of our sites, would cost 2.2 million per annum, but actually would save 1.4 million net in the bed days returned to the system. So there is our national ESD team and why the fundamentals of Slowing to Care and why we feel that ESD is a real model for Slowing to Care. And we've been encouraging the government to see this and to invest with us on this, given that it's their model for the whole health service. We also defined what is an ESD team. There isn't an agreed definition of what is an ESD team. I was very keen that a clinical nurse specialist come into the ESD team, particularly with regard to, as I remarked, the nursing home situation. I also felt that a therapy assistant would be very good in order to maximize both the efficiency and the number of patients that our physiotherapists and occupational therapists and speech language therapists could treat. And so that was our agreed definition from the working group of what constitutes our ESD team. Stroke key worker, we got a job plan agreed with the HSE. We want to put a stroke key worker in each of our community health organizations. We realize we have a dearth of 17 posts in psychology needed across our CHOs, and we also wanted patients to have access to their own stroke passport. Probably paper initially, but increasingly moving to digital. Lastly, about research and education, I'm a passionate believer that academic involvement is important. For example, our thrombectomy service is such a success because we took part in a trial, the ESCAPE trial for thrombectomy, as did your own centre in Queen's and Belfast, but that left us with a model of working together, and in fact, it's that model that is facilitating the high thrombectomy pathway still. I'm very keenly interested that public education and research into public education also takes place, and that we also make education and research part of everybody's, if you like, daily routine within stroke, as stroke is a very fast-moving area of medicine, and we wanted to try and support that. And so, again, with regard to, we feel our universities should have a chair in stroke medicine to drive research in stroke. Let's make no apologies. Every university has a chair in cancer almost. Why don't we have a chair in stroke medicine across our clinical universities? And so we're very keen for that to happen. And that needs to be supported by research fellows as well, of course. But we also wanted continuing professional development support for everybody who works in stroke. And we plan to administer this through the Royal College of Physicians of Ireland, a bursary open for everyone for approved stroke courses. Similarly, we want enhancement of public awareness campaigns in education. This will be done through the HSE or the comms, but will actually be probably administered with, or will probably be by, if you like, by campaigns through the Irish Heart Foundation, Irish Patients Association, etc., and various aspects, or as maybe SPAFI with regard to atrial fibrillation. But we're seeking an investment of 300,000 per annum protected for stroke awareness campaigns or allied campaigns such as atrial fibrillation, hypertension. Best practice, closing the loop on audit. We successfully got our stroke register to become one of the family of audits at the National Office of Clinical Audit. So INAS, which is our SNAP, Irish National Audit of Stroke, INAS, very modeled closely on INAS, on SNAP, but we want to close the loop. So if INAS, if you like, identifies deficits, we want to be able to respond. And the only way you can respond is by having a systematic QI approach to the deficits identified. And so we're seeking a specific investment both in QI and guideline development for stroke services through the RCPI. In that regard, I've been working closely with colleagues in the UK colleges, and we're very keen that we develop the new intercollegiate guidelines will be inclusive of all the 5 nations on the islands. And so we're going to try and more collaborative approach rather than they be Scottish guidelines or Irish guidelines or London guidelines. I think we need to come together and have an agreed guideline across our nations. So big data, of course, can be scary. It will probably point out things that we're not doing well, but that's what we need to know. And that's what informs us how we respond and invest. So in concluding remarks, this is an initial strategy to put our stroke services on an appropriate first footing for the modern care of stroke. It represents a total costing about €22 million investment in staff, equipment and communication. The implementation pathway is currently being designed. We plan to have an implementation review and a next step strategy to commence in January 2025. And my program manager job is becoming vacant, I think, shortly as our program manager moves on. So our overall strategy, as I said there, it's been accepted by the Chief Clinical Officer of the HSE. Phase 1 of the strategy has been submitted for the 2021 estimates process. That's the budget for 2022. We've asked for 10.2 million. We want to get cracking and we're concentrating on our thrombectomy stroke unit CSD teams and a public awareness campaign. A lot of people are involved in this, the various groups, a lot of skill mix from all walks of the stroke life, and I want to thank them all publicly for that. Also, my colleague Liam Healy in Cork was able to use this strategy as leverage in order to get traction locally, and actually 48 jobs he got approval for to get. He's one of the thrombectomy centres down in Cork, so he was able to use the strategy already to leverage off local management, knowing that the funding is likely to come. I also want to thank my 3 program managers, Dina, Joan and Lara, and also all of my colleagues, both in the Clinical Advisory Group and at Tal University Hospital. And on that note, just to thank you for your patience in listening to me, and I hope you've got something that may be of some use to you locally.
Rowan, can I thank you very much indeed for the presentation. Absolutely fascinating, but so much detail and so much stuff to take in. If you don't mind, I would hope to distribute your slides to all our participants. It is incredible the amount of detail that you have provided, and so interesting and so encouraging to us, I feel, in Northern Ireland, to see the progress that you have made with your strategy. It's certainly, I would feel, it will be encouraging to us and give us a momentum to get moving with our own. And I wish you every success with it. Now, there's plenty of people itching to ask you questions, but what I intend to do is maybe move through all the speakers and come back at the end and do a question and answer session together. Rohan, if that's okay with you, if you don't mind staying till later. What we'll do is in the gallery with a microphone we'll pass round towards the end, and people can ask questions that way. And for anyone who's joining us online, you can use the chat function and send questions in that way, and we'll read them in the room, and they'll be passed forward to me, and I can ask them on your behalf. So I'll move on to our next speaker, who is Professor Gillian Mead. Now, Gillian is the Chair of Stroke and Elderly Care Medicine at the University of Edinburgh. She received her medical training at Cambridge University, and she's worked in Liverpool and London. She has been Senior Lecturer in Geriatric Medicine in 2000 and is the incoming President of the British Association of Stroke Physicians. Gillian, can I hand over to you now, please? Thanks.
Thank you very much for that kind introduction. I'm just working out how to share my slides. You just bear with me for a moment. It worked beautifully when we were practicing.
We can see your slides, Gillian. Just need
to
go
you can?
Full
Excellent.
screen. Yeah, but you're not full screen. If you just go to slideshow on full screen.
All right, hold on. Slideshow. Wait a minute. Sorry, it's
to the right. Keep on going to the right.
Yeah. There we are. Can everyone see that?
That's good. Thank you.
Grand. All right. Well, I'd like to thank you for your very kind introduction to speak today. I'm going to talk about life after stroke, very much from the perspective of a researcher and clinician, and I'm particularly going to focus on the role of exercise training in the stroke pathway. I'm also President-elect of BAS, which is shortly going to become BIAS, the British and Irish Association of Stroke Physicians, and I'm delighted that this is happening, and it will give us an opportunity, as Ronan says, to work much more closely together and share expertise. So next, my disclosures. For some reason, I can't seem to move my slides on.
Try spacebar right left, maybe, Gillian.
Spacebar right left. Nah, nothing's working.
Or possibly arrow right, arrow left.
Right arrow left. Yeah, there we are. Right arrow left. Thank you very much. Yeah. So here's my disclosures. So I've received research funding for life after stroke, also some royalties for work on exercise training, which I've used to support further research. And I should also admit that my own personal experience of the health benefits of exercise is partly what promoted me to be interested in this area. And I'm very proud to say that I ran a 10K yesterday, personal best, and raised some money for Chest, Heart and Stroke Scotland in the meantime. It's just sticking again. I'm sorry about this. Oh, there we are. So why does life after stroke matter? We've already heard that stroke is still the top cause of major disability in adults, despite all the advances in acute care. And even so-called minor stroke can cause major problems, long-term problems which affect quality of life, such as fatigue and cognitive problems. And the predicted number of people living with the effects of stroke is forecast to double to 2.1 million by 2035 due to an increase in the incidence of stroke. We've probably all seen similar slides to this. Here are some of the patient experiences of life after stroke. Rather gloomy comments: care falls off a cliff, it's a black hole, non-existent care. And it's fantastic to see life after stroke being given the priority that it needs in various strategies. So what are the priorities for life after stroke research? I was proud to be part of the James Lind Alliance priority setting partnership with the Stroke Association, and I represented Cochran Stroke. And our aim was to identify top questions for research around acute treatment and also life after stroke. And here are the top 10 priorities for life after stroke research. And those of you who work clinically will not be surprised about these. So psychological problems, cognitive problems, communication, understanding fatigue, how to organise community stroke services, long-term impacts of stroke on everyday abilities. There are questions about the time, place and amount of therapy, how we should work with stroke care teams, support for carers. There's also questions around the role of strength and fitness training for recovery and stroke prevention, and questions around carer and stroke survivor experience of the pathway. Now, when I was preparing the talk, I thought it would be really helpful to try and talk about everything. And then I realized that because of sort of huge topic area, it would be impossible to do any of these individual topics justice in the time available. So I've decided to focus on strength and fitness training, where I do have a experience of having done some research in this area and tried to develop services. So I thought I'd share that with you and then try and link that to how it might influence some of those other areas. So physical fitness after stroke, I'm sure you're all aware that the main types of fitness are aerobic fitness, which allows you to run, swim, and also strength and power, which enables you to do simple things like getting up out of a chair or getting up onto a bus. We know that fitness after stroke is impaired, and this is because direct oxygen uptake is reduced, muscle strength and power, even in the unaffected side, is significantly reduced. And we also know that the oxygen cost of walking is actually substantially increased. So you've got a reduction in fitness combined with increased demand. And these fitness impairments that we see are associated with disability. So several years ago, I started working with an exercise physiologist, Dave Saunders and Carolyn Gregg, to start to ask the question, might fitness training improve outcome after stroke? My slides are stuck again. Sorry about the problem. There we are. So we led a Cochran review a few years ago, and here are the results of the updated version. So we identified 75 studies recruiting 3,000, mostly ambulatory patients, and they included a range of different types of training as indicated here. And we said that our primary outcomes and secondary outcomes were going to be some of those listed here. So our primary outcome was disability, and we found that cardiorespiratory and mixed training reduced disability. We had a number of secondary outcomes, including mobility, walking and balance, and these all improved. We had some other secondary outcomes, including cognition and mood, blood pressure, and there were trends towards significant benefits, but nothing actually statistically significant. Importantly, the interventions tended to show specificity. So if you wanted to improve walking, you needed to provide walking training. And importantly, there were no serious adverse events such as falls or cardiac events. We also know that exercise after stroke is a very powerful way to prevent further stroke. And this is a network meta-analysis published in the BMJ a few years ago, looking at the effect of exercise on coronary heart disease, stroke, and pre-diabetes. And here you can see the effect on exercise, and very, very significant effect. So this is another good reason why we should be incorporating exercise training into our stroke rehabilitation pathways. And exercise after stroke is also included in national guidelines and the Stroke Action Plan for Europe. So how do we actually deliver this in practice? Well, a few years ago, I worked with a physiotherapist, Frederica Van Wyk, who's now at Glasgow Caledonian University in later life training. We developed a specialist exercise and fitness training course for exercise professionals, which is analogous to those that exist for cardiac rehabilitation. And we did train a number of instructors, and they started to deliver fitness training courses throughout the UK. And then the pandemic came, resources were limited. So we've been looking at other ways of providing ways for people during the pandemic to get fitness training and later life training, provided some online exercise bites to help. But I think what we need now is to look at how we can reinitiate these links that we've developed with the fitness sector, and I'm actively working on that at the moment in Edinburgh. So I think where we are with fitness training after stroke, my view is that we need to implement what we know, but we also need more research. And on the left, you can see a flyer for the Exercise After Stroke programme that we've developed with Edinburgh Leisure, which is a council-run leisure centre. And this programme of work was developed by Mark Smith, who's a physiotherapist, and the aim was to try and get stroke survivors referred into Exercise After Stroke programmes. There are, however, barriers to exercise and motivators. We probably need more research on cost effectiveness, how to develop interventions suitable for immobile stroke survivors, and how we break up sedentary or sitting behaviour after stroke. So clearly the COVID pandemic is likely to reduce population levels of physical activity. I did a search of the literature at the weekend and didn't find much published, but here's a survey of 1,200 people in Israel, mean age 49. 70% of people said they trained less than normal. Interestingly, quite a few used digital means, and 55% gained weight. Now, if population fitness has fallen as a result of the pandemic, then the potential impact on stroke is that we might see an increased incidence, because we know that physical activity reduces the risk of a first ever stroke. We know that if you're active, you have a stroke, it's likely to be less severe. So potentially we might see more severe strokes. And it might take longer for people to recover if they're less fit, and it might lead to more disability, but we don't know yet. So I think the question then becomes, what can we do now as healthcare professionals? And I think the first thing that we should do is to talk to patients and families about their pre-stroke levels of activity. And I do this in my Life After Stroke clinic, and many people have said to me, well, I used to go out and do a lot of walking, but lockdowns have affected that. But I think we should be raising that subject, just as we talk to people about smoking and diet. And we should be starting to explore with people how they perceive exercise, the potential benefits, and work with them to look at ways to exercise more. In Edinburgh, we've had some success in introducing exercise training into the stroke rehabilitation unit, and to get your aerobic fitness up, the goal is to get the heart rate up. And what we've also done in Edinburgh is explore, well, we've set up potential pathways into community exercise services, and I think there's potential for stroke services throughout the UK and in the Republic of Ireland to look at what community services currently exist and how potentially we can link up with the stroke services. Coming back to the 10 questions, top 10 questions around life after stroke, And here what I've done is tried to summarise how exercise might impact that. So we know that exercise improves mood in non-stroke depressed patients, and it's possible that exercise may well improve mood after stroke. We don't know yet about the impact on cognition, although there are some data to suggest that exercise actually increases your brain size. So therefore, it's perhaps not unreasonable to suggest that exercise might potentially benefit cognition. We don't know about communication. With respect to fatigue, we know that being inactive and being unfit is associated with fatigue. So potentially exercise might improve fatigue. Community stroke services might look at how they then link to exercise services delivered within the community, perhaps after early supported discharge. And I think we've got good evidence that exercise improves disability. One of the top 10 questions was around the time, place, and amount of therapy. And I suppose the question here is, how can we include an element of fitness training into existing therapy? I think exercise professionals are an underused resource with a huge amount of knowledge, and I think potentially understanding how to work with them to provide support for carers and for patients is really important. And we've got anecdotal evidence of increased confidence amongst stroke survivors who take part in exercise, but I think more research is needed. So in summary, I'd like to say that exercise is an intervention that's potentially underused, that has numerous potential benefits, and is an exciting way of trying to improve life after stroke. And I'd just like to thank all of my many collaborators, stroke survivors and the carers who've advised me on the programme of research, patients who've participated in research, and these funders. Thanks very much.
Gillian, thanks very much for your presentation. And again, if you don't mind, if you can wait to the end as well, we'll take all the questions together. That presentation really resonates with us at Northern Ireland Chest, Heart and Stroke, because in addition to our prevention activities and the research, the local research that we fund in our universities and hospitals, care of patients post-stroke is a vital part of what we do. And with that in mind, I'm now going to invite up our Director of Care Services, Catherine Mernon, who wants to say a few words.
Thank you, Declan, and lovely to be here this afternoon with you. I realised when I came in that I left my notes in the car, but after not wearing high heels for a year and a half, I thought, no, I'm not going back to look for them again. Lovely to be here this afternoon, and I think, I suppose that call for time to action is really important, given that we're just trying to get back to some sort of normality within the care department and what that actually looks like. So I'm just going to take a few moments this afternoon to describe a little bit about what we've been doing and how this links into the manifesto and the work that Northern Ireland Chest, Heart and Stroke are doing at the moment. Okay, so our stroke services, we have 8 service level agreements across the 5 health and social care trusts in Northern Ireland, which doesn't seem like a lot, but it does involve a lot of work. And I suppose I just wanted to set the context there, because although we report on those services and there's quite a bit of detail involved behind the scenes in doing that, actually almost 90% of our income and fundraising comes from the Northern Ireland public. So even though we have those service level agreements with our colleagues in health and social care, obviously a lot of our work is actually funded through the generosity of our fundraisers in the Northern Ireland public, and I think it was just important to set that. So the current context, everyone else has talked a little bit about the challenges that are happening at the moment, and we're no different. The funding model that we have is a bit of a challenge, and I will talk a little bit about opportunities as well, because it's not all doom and gloom, but there is something very challenging whenever you're working in the charity sector and you're trying to provide services at a time of change and to make that impact on the people who are actually living with stroke conditions and their families across Northern Ireland. And yet there are different demands and different ways that the health and social care structures actually look for reporting, and often there is a bit of a disconnect there in what the impact we make on the ground is and what the demands of our colleagues in terms of reporting and giving the data through. So one of the things that I would hope would come out of better collaboration, and certainly the regional specification that we'll talk about in a wee moment, is a real joined up approach that we can come together, identify what the need actually is, and then look at ways that we can procure that and make sure that fundraising and funding is actually working together for a good funding model that really works well for everybody. Referral processes as well is another bit of a challenge, and again, I will probably be a wee bit negative and critical in this bit, but I'll swing that round when we talk about the opportunities as well. But we are often held to account about referral levels and referral numbers, and particularly during the pandemic, whenever obviously there was a lot of challenge in how we moved our services to that online platform. But we need the input and the support from our colleagues right across health and social care and through other pathways to actually make the referrals to us. We know that, talking to some of our colleagues in primary care, they're really concerned about delayed presentation during the pandemic. Other speakers have identified that they know there are people who have slipped through the net, and it's really important that we work together to make sure that the referral processes are clear and that everybody makes that effort to ensure that people are referred at the right time. Strategic direction as well, and I guess Declan set it out at the very beginning, and other people have talked about it as well, and it's the reason for our event today. It's really important that we do come together now and really get behind that time for action, because 2018 seems like a million miles away. We're in a totally different place. We know that people have fallen through the net. We still know that there's lots of opportunities as well, but really we need to look at the strategic vision for what stroke reform is actually going to look like and make sure that everybody works collaboratively with that. The learning through COVID, like many organisations and probably many of you here today, we have taken stock and really reflected on the last 18 months, and there has been huge learning in that. I think that Northern Ireland Chest, Heart and Stroke, I suppose, it's great that we're in our 75th anniversary year, but unlike many other charities, we did remain open, we kept our doors open, and we moved really quickly to a model of support for people so that we knew that they would have that interaction and that place to come during the pandemic when we knew that things would be really difficult out in our communities. As a result of that, we've really looked at how we collaborate better with other organisations. We know that we can't do it all on our own, and we need to take that collaborative approach, and there's some really good ideas and good things that are happening, nonetheless, with our partnership with the Stroke Association Northern Ireland, which I'll talk a wee bit about later as well, and it's great to have Barry and Ursula and other colleagues here today as well. And really, I suppose, we will be going forward with a hybrid approach. We know that online has worked really, really well for many of our clients. It's actually been brilliant to see people living with stroke come on and engage online. We've had a lot of emotion on the activities that we've run, but we've had a lot of fun and a lot of really good outcomes that have been measured and reported on, and you'll see a lot of that in the impact report that's available today here and online as well. And I suppose we've really taken that person-centred approach to our services. We've always had it, but we really worked very hard during the pandemic to ensure that nobody would be left behind, that we would use whatever means and resources we could to bring people together. So as well as running all our online activities, we had telephone support, we had postal support, we kept connected with people right through the pandemic, and actually the stories that we've heard during that talk about us being an absolute lifeline to people living with stroke and chest and respiratory conditions as well. So the opportunities, I suppose, we talked a little bit about service level agreements, and there's no doubt it is a challenge, and it's not just unique to us as an organisation. But with that comes opportunities, and we're currently reviewing our service level agreements with our colleagues in health and social care, and there's some really good conversations coming out of that. We recognise that they have been in a real period of change and flux as well. And certainly over meetings in the last couple of weeks that I've attended, there's just been a real sense of people feeling fatigued, feeling overwhelmed, and there's no doubt that whenever we put things on screen and, you know, there's different indicators around red, green and amber, that sometimes it's hard to actually see the stories behind that, and you can just be judged or measured on what a dashboard actually looks like instead of the bigger picture. So that's where collaboration comes in, that we can work together for those health outcomes for people living with stroke. A real co-production approach for us is really, really important, and I could stand here all day and talk about the stories of people who have come through our services, and honestly, they can teach us an awful lot.
And in all the strategic drivers that our health and social care structures have, co-production seems to be very much a focus there, and I would really like to see that being put into reality, because it's not good enough that it's just in a paper. There's really good examples of it happening well, but we need to do more. We need to listen and value the lived experience of people living with stroke, those who are patients and the carers as well, because they have got very good, powerful stories to tell, and actually really good solutions to some of the problems that are out there as well. Health and equality focus for Northern Ireland Chest, Heart and Stroke is really important too. And I think, again, just looking on the impact of the pandemic, where NICHS figures and different publications from world leaders like Sir Michael McBride, who shows us that the impact of the pandemic has been harder felt in those areas of deprivation. And we know the risk factors in those areas of deprivation would suggest that people will be more likely to develop chest, heart and stroke conditions and also live with comorbidities. So it's really important that we embed that inequality focus. And again, I know that that's a strategic driver and a lot of the health and social care documentation. So let's work collaboratively to try and put that into practice as well. I'm not sure if you can see this all in detail, but there will be copies of the slides, and we do have this in a standalone PDF. But as a result of learning from the pandemic, we reviewed our 3 pathways in chest, heart and stroke. And as I mentioned earlier, with comorbidities and different risk factors, we have a number of clients who are living with respiratory, stroke and cardiac conditions. So we tried to look at ways that we could collaborate better across our care team and indeed with our colleagues in prevention. And we came up with a revised pathway that really is about how people engage, how they come in through our door in the first instance, and then how we take them through a series of services, needs-based assessments, and then a discharge point. Because again, we want, as other people have talked about, to empower people. We want to give people the tools and the techniques that they can live life to the full. And we want to also make sure that we reach everybody that's living with stroke in Northern Ireland, because it's not good enough that, you know, we just have the people who are coming through mainstream referral processes. We need to be out there and looking at who else is in the community who has slipped through the net. So our stroke family support is really the bedrock of what we offer within the charity across our stroke services. And people will come through that and they will be given a full family support assessment and access to our dedicated and expertise in our care team. And as a result of that, there will be different signposting and different pathways that they can come through into other services. We work really closely with our colleagues in Stroke Association Northern Ireland as part of a joint referral pathway, and that has really streamlined I suppose the referral process for our colleagues in health and social care, and also for patients who maybe with the best will in the world can be confused about things in that really difficult time around diagnosis. And, you know, why should they have to navigate that system? We want to make it as easy for them as possible. So when we bring people through family support, we will then identify what other needs are there, and listed within that, and Gillian made reference to it earlier, around the benefits of exercise. So we offer our evidence-based PrEP programme, which is post-rehab exercise. Obviously, we had to put that on hold during the pandemic just because of risk factors, but we're back out there developing plans just at the moment, and, you know, looking at venues, adhering to the different restrictions through our public health colleagues, but also really keen that we get people back up and move it again in a way that's right for them. We also have walking groups as part of that as well, so we know people will be at different levels, and again, it's just really about bringing people together, getting them moving in a way that's right for them, that meets their needs, but again ties into that whole secondary prevention model as well, that keeps people well and keeps them moving. As well as that, we have our self-management programme, and again, really interested to see in lots of the documentation around building back better and the future of health and social care programmes, that self-management is at the core of that. In Northern Ireland Chest, Heart and Stroke, we have our evidence-based self-management programme that we deliver under licence through Stanford University. All of our staff who deliver that are trained, and it's very much about goal setting, and we have seen huge changes in a positive way for people living with stroke who've actually come through that. And the real importance of peer support as well. And I think that is something that's really shown through during the pandemic, where we have been able to bring people together, even if it's been virtually, and you can just see where people connect and they actually feel that they're not isolated, that anxiety that they have actually reduces, and they're more empowered to take control and to look at ways that they can actually manage their condition better. And then staying connected, and that's really, I suppose, our new approach to what stroke support is in the community. And, you know, over the years and for different historical reasons, we have had a varied approach to this, but we're really clear now that we want to bring people together in a very much health and wellbeing outcome focused way. So we are organising a series of workshops and different activities where people will come through, and depending what their need is, we will build programmes around that, and that will not just be for the person with stroke, but for their carers as well. And we also have a separate carers education programme, because some of the complexities of the cases that are coming through at the moment have really highlighted for us the impact that the pandemic has had on carers who have been very isolated during any, suppose, respite or support for them, and we need to make sure that we have our services supported there. And then obviously we will look at a discharge process with that as well, because we want people to be in the right service that's right for them, and then that we can refer them on to other services or really make sure that they're supported well in their community. We know that there is fantastic support there through our primary and secondary care colleagues, but really people living with stroke and their families will live for the vast majority of their lives without that connection to primary and secondary care. So I think we're really best placed in the third sector to enable and support and work in collaboration to keep people as well as we can do whenever they reach that stage. So joining up, and again, I suppose we are here in the care team, but we cannot do our work without other parts of the charity. And it's brilliant that we've a real collaborative approach across Northern Ireland Chest, Heart and Stroke, and that will again take us out to really good collaboration in the community too. But our impact report, which you will see today, it just highlights the different pathways where we can link in together. So primary prevention and secondary prevention, the research that people have talked about earlier that has enabled us to do things like our PrEP programme and other research applications that are coming in at the moment. The whole area of communications, where we're trying to raise awareness of stroke and make sure that the patient voice comes through at all times as well. And also linking into things that have been mentioned today around AF and prevention services, because again, we know those comorbidities and the increased risk factors. So it's really important how we can work collaboratively to make sure that those things are affected in terms of change at local level. We're members of NICHS, the Stroke Network, and the Basque Five Nations, who have been speaking earlier today as well. And that has given us, I suppose, a real sense of what's happening across other platforms and networks. It's helped us to create opportunities where we can share and collaborate better, and it's also helped us to make sure that the patient voice is key there, because often they're the people sitting in their local communities that don't have that space or that place to actually advocate for themselves, and that's really a fundamental reason why we're involved in those different networks. And again, collaboration, which is a word I've used quite a bit today, but we cannot do this on our own. As I say, we work closely with our colleagues in the Stroke Association Northern Ireland, the Healthy Living Centres, particularly with their focus on health inequalities, and we've been doing some work, particularly with the health inequalities work that's happening within Lisburn and the ICPs as well. And I know my colleague Fidelma has been involved in different work there around AF and the stroke pathway, so it's really great to see those opportunities coming together. People have talked a lot about early supported discharge, and we know that our colleagues in the Red Cross during the pandemic have been doing a lot of work with people living with chest, heart and stroke conditions. So we're working in partnership with them to identify better ways that we can support after they come out of that family home and the person has a need around stroke. And then Advice Space, which is a service that we fund within Northern Ireland Chest, Heart and Stroke, where we can refer people through for benefits and other financial advice. And as you can imagine, if you're someone who's been working and holding down a job and you have a stroke and you've had to give up work, the implications for that on families are huge from an awful lot of different reasons. And we have been delighted that we've been able to support people and generate benefits to the tune of almost £400,000 in the last year, and that is really fantastic to see that impact on the ground. We have streamlined our referral process, and that has been, I suppose, at the request of our colleagues within the Health and Social Care Trust, feedback from others and the collaborative approach that we're taking, and also feedback from people who we actually support with a stroke. And we now have centralised and streamlined all of that to make it really clear and much more easy, which enables then our own support workers within the care team to have the checklists and the assessments to take that first journey with the stroke patient and make sure the services are right for them. So that's just a whistle-stop tour. As I say, I could stand and talk about this all day today, but I'm not sure if we have the video as part. If I just go ahead and click again, yeah. So these people can say it much better than me.
You know, watching this, maybe there's someone who's just experienced something similar, has had a stroke. You're both here today. life does go on, it just goes on very differently. What sort of person were you before stroke?
I was a very outgoing person. I've always been a bit of a wind-up merchant, bit of a joker and things, and I would have played golf 3 times a week.
Right.
That doesn't happen.
Okay.
It's been a complete social. I don't interact, don't go out. Obviously, COVID hasn't helped, but I just withdrew in and...
What's been the hardest thing, Derek?
Depending on other people. I think that is the most frustrating, and it makes you aware of what you maybe took for granted before. And there's people, people don't realise that it's some things that you can't do now, and how frustrating it can be. That can get your emotions completely messed up, and it's frustrating. And I'll say it as before, sometimes you get to a stage where you just say, don't want to do this anymore.
Can you relate to that, Alison?
Yes, certainly. Hate being a burden to people, and the loss of independence is absolutely terrible. I got to the stage where I found it very difficult to go out. I'd lost my confidence, which is very strange because I was always very confident.
Yeah.
But and then you just have to work and plough your way through it. And 3 years later, I can hardly believe that I've progressed.
Time for action.
Catherine, thanks very much for your presentation, and also thanks to Derek and Alison there for giving us the very important patient perspective. I said earlier that the last 18 months has been a very, very difficult time for everyone at Northern Ireland Chest, Heart and Stroke. But when I reflect back through that difficult time, one of our greatest achievements, and I say this as the Chief Executive for the whole organisation, one of the things that makes me most proud is the way that we continued to provide services to some of the most vulnerable people in society who depended on our services. And I'm grateful to Catherine for outlining the way that we did that. And literally we moved mountains to try and accommodate the people who depend so much on us. And also thank you, Catherine, for explaining in detail how we are addressing and living up to the challenges and the opportunities that lie ahead. And our services are now in a fantastic position for people to avail of them in the future. So without much further ado, I want to move on to our next speaker, who was well known before COVID, but I think he's known to everyone in Northern Ireland at this stage, Professor Sir Michael McBride. And for obvious reasons, he is not doing many public engagements, so we're very grateful that he's been able to squeeze us into his very busy schedule. So thank you very much for joining us, Michael. Without further ado, I'll hand over to you.
Okay, thank you, Declan. And listen, might I thank you for the kind invitation to speak with you this afternoon. Also, can I take this opportunity to thank the Deputy Chair of the Health Committee for sponsoring this event, and for all the elected representatives who have attended either in person or virtually. Events like this are extremely important because they allow us to take stock of progress, celebrate our successes, and there have been some, as we have heard, share learning and best practice, and most importantly of all, to take a look forward at the challenges and the priorities ahead. I therefore very much welcome the launch of the Northern Ireland Chest, Heart and Stroke Manifesto, with its recommendations to further drive improvements in stroke care. And I would like to extend my thanks and my appreciation to those in Northern Ireland Chest, Heart and Stroke for their ongoing efforts to improve services for stroke survivors and their carers. And again, bringing the priority and shining the light on the need for further improvement through events such as this today. I very much welcome the update from Professor Ronan Collins on the National Stroke Strategy, which sets out a broad programme of work to improve stroke services in Ireland through to 2025. We face common challenges, and as he said, it's very important that we learn from each other. There are certainly plenty food for thought and much for us to consider in the strategy. The need to make improvements across stroke services from prevention to acute care and community support has been emphasised today. And Professor Gillian Mead, who spoke powerfully about life after stroke and the importance of rehabilitation for stroke survivors in the community. Here in Northern Ireland, many of you will recall the department's consultation, Reshaping Stroke Care, Saving Lives, Reducing Disability, made commitments to deliver change, including improved access to TIA screening, the establishment of a hyperacute stroke network in Northern Ireland in order to maximise the potential of hospital treatments. Over 1,600 people participated in consultation events on 7 events. There was a lot of discussion, a lot of debate. I covered a lot of miles, and I want to thank the Chest, Heart and Stroke Association for all of their work in attending those events, facilitating those events, and ensuring that we heard from the voice of people such as Derek and Alison, which actually made those events very real events, very human events, when we heard at firsthand the devastating impact that stroke has in people's lives, and the fact that we can do more, we can do better, and we need to do more, and we need to do better. We received over 19,500 consultation responses. And it was clear from the volume of responses that were received that people feel passionately about stroke. And they feel passionately about stroke services. Those who responded to the consultation expressed support for the development of community-based services for stroke survivors and their carers, along with a strong attachment to stroke services at their own local hospital. The majority of concerns raised reflected the view that those affected by stroke in rural communities may suffer poor outcomes due to additional time travel if services were reconfigured onto a smaller number of sites. The department has finalised the consultation analysis and did so back in the spring of 2020. And following that, the Minister requested further analysis of the workforce requirements for future stroke services. Although this work was paused in order to redirect resources to respond to the COVID pandemic, that work has now recently been completed. That analysis is finalised, and it is currently with the Minister for his consideration. And it is hoped that we will be able to discuss with the Minister the next steps in the near future. While we await that discussion with the Minister, it is important to note, however, the ongoing improvements being made to stroke services. And these have been largely led by the Stroke Network, which I know Northern Ireland Chest, Heart and Stroke plays a key role in. Many of these developments are fully aligned with the commitments made in the Reshaping Stroke Care consultation. A recent TIA re-audit identified recommendations to improve TIA services, including TIA pathways to be reviewed to provide earlier access to a specialist assessment and a move to a 7-day-a-week service for patients with suspected transient ischemic attacks to ensure accessibility to specialist and appropriate imaging. The Stroke Network will continue to make progress in line with these recommendations, which will also be incorporated into the future outworkings of the Reshaping Stroke Care consultation. We remain committed to identifying ways to further improve thrombolysis rates. This, as you know, is performance managed through mechanisms such as the SNAP audits and the Health and Social Care Board monitoring arrangements. And we're also continually seeking to drive improvements through the application of quality improvement methodology. Quality improvement leads work to improve the performance of the thrombolysis pathway by identifying areas for improvement within trusts, such as time from admission to scan. They also highlight where there are external factors causing a delay in patients presenting, which could benefit for awareness campaigns such as FAST. And significant progress has been made in reducing door to needle time of thrombolysis, and current median times range from 21 minutes in Southwest Acute Hospital to 48 minutes at Antrim Hospital, and the current Northern Ireland median is 39 minutes. We do, however, need to reduce that variation. We're also considering the use of artificial intelligence, which can assist with the interpretation of scans, and this may also increase the time window in which thrombolysis can be provided. At the outset of the Reshaping Stroke Care consultation in 2019, thrombectomy was available 5 days per week. Early last year, despite the pandemic, we moved to a 7-day week service from 8 a.m. to 5 p.m. And in total last year, 131 procedures were carried out. And this includes 49 patients at weekends who would otherwise not have benefited from this life-changing treatment. In line with the commitment in reshaping stroke care, planning is now underway on the further expansion of the service as we build towards a 24/7 service. The Stroke Network's community specification document sets out the criteria for community integrated stroke and long-term care services with the aim of delivering high-quality care that supports all stroke patients on discharge from hospital-based inpatient care to their place of residence. And more widely, as you will already be aware, the way we plan, manage and commission our services within health and social care is evolving. Indeed, the consultation on a new model for planning health and social care based on an integrated care approach has just closed. This new model, known as the integrated care system, seeks to empower local areas to plan, manage and deliver care for their local population based on their needs and embeds collaboration and integration at the very heart of that planning process. It is important that the needs of stroke patients and carers and the role of charities such as Northern Ireland Chest, Heart and Stroke are reflected in that model. And I very much echo the points that Declan made in his introductory comments about the need to ensure it is fully embedded in those processes. While recognising these developments, it is also important that we also acknowledge the unprecedented nature of the situation that we have faced over the last 18 months. And we will continue to face for some time yet. Progress which was being made, unfortunately, has been delayed. Our health and social care system is under pressure like never before and continues to face ongoing pressures moving into what is going to be an incredibly busy winter period. I therefore want to take this opportunity to pay tribute to the work of all health and social care staff who continue to perform at the highest level under such difficult circumstances. I know the stresses and strains our workforce is under, and I admire the ongoing commitment to provide the best possible care. I also want to put on record my thanks to our partners in the community and voluntary sector, and indeed in all of the charities, in what has been a tremendous response right across society. And while we continue to face very challenging times ahead, I would like to provide assurance that the department remains fully committed to driving forward improvements in both hospital and community-based services. We can and we must do better for stroke patients and their carers in Northern Ireland. We have simply unfinished business and we need to make progress to improve the outcome for people who've had stroke, completed stroke in Northern Ireland, and as importantly and more so, as we've heard, to prevent and address the risk factors so that we, in the months ahead, can point to sustained momentum and progress on the implementation of the recommendations of the review. Thank you very much indeed.
Dr. McBride, thank you very much for joining us today. It's very much appreciated. And on behalf of everyone at Northern Ireland Chest, Heart and Stroke, I want to thank you for your efforts in leading the response against the COVID pandemic in Northern Ireland. It's very much appreciated. And we wish you every success with your future endeavours in that regard. Now, before we wind up, there's time for questions. So firstly, from the floor, if anyone has any questions, we have a roving microphone. And if you put your hand up, I'll get the microphone brought over to you. and it would probably help if you maybe introduced yourself before your question and then let us know who you wanted to direct your question to. Anyone?
Hello, my name is Niamh Kennedy from Ulster University, and I just want to ask Ronan a question. First of all, to congratulate you on great work done in the Republic of getting the stroke strategy up and running and keeping it on track during COVID. And you had some really nice KPIs and specific percentages around your acute care, and you gave some good suggestions for life after stroke in the more long term. And that's something that we're aware of from our 2008 review and our reshaping of stroke services at the minute, that often we lose momentum moving from acute into long-term and community support. I was just wondering, had you set specific targets to get your 5 suggestions into practice, or how you were going to ensure that momentum kept going from acute into long-term?
Thanks, Niamh. First of all, thank you for the kind comments. I am, of course, just a spokesperson for a large group of people. That's a lot of people.
Sorry, Rohan, sorry to interrupt you. Rohan, can you adjust your volume there slightly? We're having some difficulty hearing you here.
Try this speaker again.
Better, that's better.
Yeah, can you hear me now?
Yes.
Yeah, okay, sorry, yeah. So apologies. So I was just saying, Niamh, thank you. Of course, I am just a spokesperson on behalf of a large body of people, and I mean that in a genuine sense. So the stroke strategy is the work of lots of different people. KPIs are interesting, Niamh, because they're probably a thing of the past politically. And I mean that when we went back, these were original KPIs we had. And when we went back to look for different KPIs, or could we change the KPIs, the government were very keen not to have KPIs, because KPIs become a stick by which government can be beaten up on. And so that's one aspect of it. I rather think, though, that now that we've got INAS independent and at arm's length from the HSE and from the stroke programme, that they will set the agenda and that they will periodically audit things that we feel we should be achieving, and if we're not, that they will create a focus on areas where we're underachieving. So I think we probably won't get new KPIs, although I would like some KPIs, but I will be dependent on INAS to deliver on KPIs by focusing on areas where we're underachieving. Going back to the focus on, how do you keep momentum going? Again, I think having an independent audit with a strong steering committee that can look at areas of stroke, like, for example, swallow assessment, look at quality of blood pressure control and prevention targets, detection rates of atrial fibrillation within primary healthcare. Again, I think that's the importance of having an independent audit removed from government, removed from the health service, removed from the stroke programme even, so the stroke programme isn't auditing itself. So you have to be brave in one sense to do that, but it's important because you must face the rigour of audit and accept what audit tells you. And that's why I think it's also important when you go back to closing the loop, that you've got that resource around quality improvement to focus on the areas where audit tells you you're doing poorly. So I hope some of those comments go some way to addressing that. But as I said, I think having independent, very vigorous and enthusiastic auditors is the way forward, probably.
Okay, thank you, Rowan. Any other questions in the room? And just a reminder to anyone who's watching us online, please use the chat function if you have any questions, and we'll receive them here and they'll be fed up to me and I can read them on your behalf.
Hi, I'm Dr. Brian Gell. I'm a consultant in Southwest Acute Hospital in stroke medicine. My question's to Professor Mead. Obviously, you've done an awful lot of research regarding exercise after stroke in a research forum. Is that being provided locally in Scotland or even in the Edinburgh area to the general population? Is it provided at all, or is it provided by the health service or councils or charity sector?
I think there's a real mix. In Edinburgh, we work closely with Edinburgh Leisure, and we got some funding to train instructors so we could provide exercise classes and gym sessions on a one-to-one basis with stroke survivors that was funded. Then the instructors that we trained moved on. We're now working again with Edinburgh Leisure to reinvigorate that. It's going to be a cost for stroke survivors to attend. And what I would love to see is actually a service level agreement between the health service and Edinburgh Leisure to deliver exercise after stroke in the same way that it does for cardiac rehab and pulmonary rehab. And I think that's the way forward. In other parts of Scotland, different models exist. So Glasgow has got Glasgow Life, which provides suitable training opportunities for stroke patients. So I think it's very patchy. It's not as widespread as I would like it to be, even though it has been in the Scottish CHD and stroke strategy for some time. And I think actually implementing that evidence in practice is very difficult, and it requires demand from stroke survivors understanding the benefits of exercise. It requires healthcare professionals to refer people in. It requires exercise in the community, for example, Edinburgh Leisure, to have more of a presence on stroke units to raise the profile of its importance. So I think it's very difficult to implement. So yeah, so I think there's different models in different places. But as a first step forward, I think we should all, as healthcare professionals, be asking people about exercise just as we do ask them about smoking, because that is a very well established risk factor for stroke. And it is in keeping with what the World Health Organization recommends as well around exercise for people with chronic health conditions. I'm not sure whether you've answered your question, but it's very patchy, difficult to implement, but I think we can all do our bit.
Okay, thank you very much, Gillian. Have we any other questions in the room there at the back?
Yeah, thank you. Colm Gildernew, Sinn Féin Health Spokesperson, Chair of the Committee, and glad to have sponsored today's event along with Pam Cameron. I suppose this has been quite a journey, and I want to commend Chest, Heart and Stroke for putting today's event on. One of the first events, certainly I think the first event that I've attended back in the Long Gallery. But this has been an extensive consultation, extensive engagement with the public, and a very long and a hard journey. And I suppose everyone is keen to see when the near future is in terms of when all of these strands will be pulled together and we'll start to see some reporting. And I suppose also there's an outstanding concern around what the impact of COVID has been, not only in terms of reduced presentation, interruption to treatment, and indeed maybe the direct effects of COVID and long COVID in these types of conditions. So I just suppose it's a huge amount of work to be done, a lot of work done already, but it would be good to see it starting to come together in as timely a way as possible.
That's right. Colm, thank you very much for attending. Yes, we would agree with that. I mean, we're all looking forward to the outworkings of the consultation as quickly as possible. Obviously, the last 18 months has been very, very difficult for anyone connected with the health service. There's been other priorities, but as I mentioned earlier, we're now at the point we do appear to be coming back to some sort of normality. And it's time for things like the stroke consultation to be put back on the table. And I think that's the message from us today, is these things cannot be forgotten about, and they need to be addressed as quickly as is humanly possible going forward, because it's people's lives we're talking about. Anyone else in the room? Are they online questions? Yeah, I think my colleague there, Neil Johnson, is going to read out some of the questions that have come in online.
Sorry, just a very quick one here there's been texted in from Dr. Dermot Maguire from Clifton Street Surgery, just asking for Ronan, aimed at Ronan particularly, about suggestions around opportunistic detection of AF in the community.
Yeah, thanks, Neil. And again, thank you personally for the invite to speak today as well. Atrial fibrillation is very close to my own heart as probably the most significant risk factor for stroke, particularly in later life. Although my previous comment about hypertension being the root of all evil, I think it's very important for us to recognize that if you want to age healthily, you've got to protect your end organs. And your end organs are most damaged by high blood pressure. And I think all of us need to recognize that. If you want to cure dementia, cure blood pressure in people in their 40s. If you want to stop people becoming blind, treat blood pressure in their 40s. If you want to stop people falling, developing vascular gate dyspraxias, treat blood pressure in your 40s. Kidney failure is an epidemic of dialysis need, most of it again related to blood pressure, some of it related to diabetes. And again, most atrial fibrillation is due to high blood pressure, most of it. Now, that being said, there obviously is a cohort of people that have atrial fibrillation that we cannot turn the tide back, although I still think that good control of blood pressure will lessen the burden of atrial fibrillation. The recent LOOP study in the European Society of Cardiology was a disappointment to most of us who felt that if we screened more and more, we would see a reduction in the numbers of stroke. There has always been an argument about screening for atrial fibrillation that it's not just about finding atrial fibrillation. The screening program has got to prove that it will then reduce the incidence numbers of stroke. There's two comments to make about this. Not everybody's atrial fibrillation is the same. Atrial fibrillation is not the same in the same moment in time. For example, if you have atrial fibrillation when you have a pneumonia, it's probably more likely that your blood is more likely to form a clot being thick and full of antibody than if you had atrial fibrillation when you don't have a pneumonia. The same would apply if you had an underlying cancer. And so it's a continuous variable of risk. But going back to Dermot's question to me, I think there isn't evidence yet, although I am pro-screening and looking for atrial fibrillation. I don't think we've evidence yet to say anything more than opportunistic pulse taking is probably as good as it needs to be at present. But I would add this caveat. If you have a patient who has high blood pressure, diabetes, or heart failure, and is in their 60s, there's a fair chance that the incidence of paroxysmal atrial fibrillation in that group of people is somewhere between 5 and 10%, and they're probably worth screening, if you can do it.
Thanks, Ron. And I think from our perspective, probably some of the frustration we feel, given our prevention activities, is that the tests for AF, and particularly for high blood pressure, they're not expensive. These things are quite easy to detect. And I think that's, a frustration we feel that testing isn't more widespread. And certainly we know through our own checks, when people come to us, maybe they feel reluctant to go to their doctor or to somewhere else. When they come into our offices for the health checks, it's shocking just to see how many instances we do detect of high blood pressure from people who have clearly no symptoms and are completely unaware that they have this problem that increases their likelihood of not just heart attack and stroke, but all those other illnesses that you talked about.
Well, I think there's my understanding is that there's 2 MLAs in the audience anyway, if not more. And I think it's important that we do engage with our politicians. Medics have been traditionally poor at engaging with politicians in explaining the nature of the problems. I think COVID may have changed that relationship, that there's a greater understanding that, society, we all have to listen to one another. Nothing can happen unless our politicians understand the nature of the problem and put a strategy in place with us. And so to the politicians who are there, I would re-emphasize this, that in order to give people a quality of life, I know Gillian will know this well-known phrase within geriatric medicine, it's not just about adding years to life, it's about adding life to years. We want people to age healthily, not only for their own sakes, but for the cost to society, that if we don't, and we have an aging demography on this island, and it's very important that we invest early on in people's blood pressure control. I'm also going to say this, I did work in Leeds Bradford, and the Republic of Ireland, of course, is changing a lot as well. I am seeing malignant hypertension in our immigrant population, the likes I haven't seen since I was a medical student. We really have to ensure that our minority populations are being involved in our health service, and they're a particular risk. And again, it's in everybody's interest that we identify this particularly vulnerable group of people for high blood pressure and diabetes in our society. But as I said, I'm going to say Niamh Kennedy, I know, is in the audience. She's done a lot of work in atrial fibrillation. We did start an initiative 18 months ago. It got ruined by the pandemic. I'm going to try and restart it. I wanted to ideally to be an all-island initiative, and that we can come up with common positions on atrial fibrillation, how best to detect it, how best to treat it, what our pathways are like for cure. And I would like that to be an all-Ireland initiative. So as I said, I might reach out to Niamh afterwards to see, can I get some people from Northern Ireland to join the SPAFI group and to try and make this an all-Ireland initiative for atrial fibrillation.
Okay, well, she's smiling, so I think you can take that as a positive indication. Have we any other questions, Neil? That's us. Okay, if that's us, I'll wrap up the event. Can I thank Rowan Collins, Gillian Mead, can I thank you both for joining us today and for your very insightful presentations. I also want to thank our Chief Medical Officer, Dr McBride, our own Catherine Mernon, for her presentation and insight into the work we're carrying out in Northern Ireland Chest, Heart and Stroke. And also thanks to Derek and Alison, who have the lived experience of life after stroke, for joining as well. And to everyone who has attended here in person in Parliament building in Belfast, and to everyone else who's attended online. We're very, very grateful, and we hope you found it enjoyable and informative. Thank you very much indeed. Good night. Safe home, everyone.
Thank you.